right, so let's talk about Migraine Aura. The pictures are all from where I work and where I live in New Hampshire and in New England, so I thought I would share those with you. Migraine itself goes through a series of phases, each attack, and not everybody gets every phase, and there's some confusion about the different phases. So I wanted to begin by talking about that, trying to clarify that. If somebody gets all of the phases, there's a phase of prodrome, which also was called premonitory symptoms, then a phase of aura, then the headache builds from mild to moderate to severe, and then there may be a period of rescue if a person has taken medication or the headache is terminated. And then, as most of you are aware, there can be a period of days where you don't feel right, where there's a post-drome as well. And each part, as I say, not everybody experiences every part of this with every attack. And the first and really important point to make is that prodrome is not aura. Prodrome can occur in somebody who gets an aura, but it can occur without an aura, and it can precede the migraine, and it can be subtle, and it can last for days, or it can be rather brief. And the kinds of symptoms that people get with prodrome include feeling unwell, nausea, food cravings. Some people will think that they're craving for chocolate and they eat chocolate and then they get a migraine, and that's actually the chocolate was not the trigger. The chocolate was part of the food craving. Changes in emotions, neck pain. And as I say, these go hours to days before headache. They can be subtle. There is, by the way, in the United States, an ongoing randomized placebo-controlled trial of one of the new Gepant medications, which are oral anti-CGRP receptor drugs, to see whether that Gepant, which is called Ubrogepant, will actually terminate the prodrome and the aura and the migraine which follows. So there may be a way to treat prodrome. In the past, various techniques have been used: biofeedback, over-the-counter treatments, anti-inflammatories. There's at least one study that naratriptan can be useful during prodrome. Anti-nausea medicines such as domperidone have been described as effective in prodrome, and we'll find out whether a Gepant would work during prodrome. But it's kind of a mysterious area, prodrome, and we know less about it than we know about aura, even though I think it may be more common. Most likely prodrome comes from an area of the brain called the hypothalamus. Now, let's get to what we're really here to talk about, which is aura. And aura should follow prodrome. It usually is before the headache, but it can occur during the headache. And of course, it does not occur in everybody who has migraine. And let's kind of look a little more carefully at this. There are lots of types of aura. And this is the International Classification of Headache Disorders. And after it says migraine without aura, everything below that are different types of aura, some of which have new names. And I won't go through every single one of these auras. Believe me, you don't have to worry. But I do want to explain about the most common kinds of aura, what causes them, and what people experience. There are 6 official types of aura within this international classification system: visual, sensory, speech or language, motor, brainstem, and retinal. And the most common types of aura last from 5 to 60 minutes. And then, as I said, the aura is either accompanied by the headache or is followed within an hour by the headache and is linked to the headache. Although sometimes people will get aura without headache, especially older patients. So you can have an aura with a migraine. You can have an aura with a headache that isn't quite a migraine. You can have an aura without a headache. You can have a migraine without aura, and other times have a migraine with aura. And for those who get both types, with and without, sometimes people wake up with a migraine and don't know that they've had an aura. There are other features of aura which I'm going to talk about, and there are longer auras and more rare auras, which I'll briefly talk about. But most important to know, although prodrome is common, those kind of symptoms that I described are common, aura itself only occurs in about 20 to 30% of people with migraine. And as I said, it does not occur with every attack in some people. Other people will tell me, nope, I do not get a migraine without an aura. I always get an aura. I always get a migraine. But I think most people do not get an aura with every single attack. And as I said, the typical aura, and that's actually a term, typical aura lasts 5 minutes to an hour and is followed by or occurs during the migraine. The most common type of typical aura is visual. The next type is called, next most common, and it's typical aura, is called hemisensory. And that's numbness and tingling on one side. And in the most common form of that, the numbness and tingling moves from the fingers to the hands and up to the lower face and tongue on one side. And that's called a chiro-oral aura. Chiro is limb. And then the least most common of the typical auras are an alteration of speech or language. And it's still typical if somebody gets one of these visual auras for, let's say, a half an hour, and then the next 30 minutes has a numbness and tingling aura, and the next 30 minutes has a speech or language aura. These can sequence, and it's still typical aura. Typical aura does not cause weakness. You can see here from the international classification that the typical aura will have fully reversible, that's very important, fully reversible visual, sensory, meaning the numbness, tingling, and or speech and language symptoms, but no weakness and none of the other symptoms that I'll talk a little bit about. So most people, when they come to see me, they have typical aura. And the typical aura is, in terms of a visual aura, is what we call positive. That is, people see something. It isn't just that they lose vision, it's that they actually see something that obscures the vision. Now, people can get negative visual aura. People can get tunnel vision. People can lose vision and just see blackness. But most frequently, they do see something. It's usually a crescent. It can be zigzags, and it gradually spreads across the vision and obscures the vision. And this type of aura, the most common visual aura, is often called zigzag fortification spectra, because this looks like the fortifications of medieval castles. It's also called teocopsia, but it's the common type of aura. When people see this picture of aura, they say, oh yeah, that makes sense. That's what I experience. I'm going to show you two other auras now that are positive. One of them will be flickering. So if you're sensitive to the flickering, you may want to close your eyes on this one. But you can see the zigzags and you can see the flashing. And the flashing is called scintillating scotoma. That is a shimmering positive visual phenomenon that obscures the vision. And then this type of visual disturbance will move and obscure more and more of the vision, and usually lasts 20 minutes to an hour. Moving from the visual aura to the hemisensory aura, the chiro-oral aura, the person will feel the tingling in the fingers and the numbness in the fingers, and then that'll move up, in this case, move up the left arm. The person on the right had it a little bit in the left leg as well. And then it goes, you can see on the left, it goes into the tongue on that side. And this person also had a typical visual aura and probably that came first, and then the chiro-oral aura, and you can see the visual aura was zigzag fortification spectra, and then that was followed by chiro-oral aura. These don't hurt. These are not risky. And so I don't want to alarm you because they are so common in migraine. Now, before I get to the hemiplegic aura, let me just say that the speech and language aura that can occur when people are asked, well, what are you experiencing? They have difficulty in distinguishing whether the problem is that they have clumsy speech or whether the language itself, the content of the language is altered. And it's been so hard to describe this that's why the International Classification sort of said, oh, we'll just call it speech or language problems, because it's a little bit of both. And it's very alarming to have your speech or language be disturbed for 20 minutes in the setting of a migraine, but it is a typical aura. Now, hemiplegic aura is weakness, and it's weakness on one side. And in order to have a hemiplegic aura, by definition, the person has to have a typical aura and then get the weakness. And they have to have a history of typical aura before they get the weakness. That's one way to distinguish, for example, whether somebody's having a migraine hemiplegic aura from something worrisome like a warning for a stroke. Somebody who develops a one-sided weakness and then a headache, but has no history of migraine or no history of typical aura, one would be very worried that that's not migraine. On the other hand, people with hemiplegic migraine will have a long history of typical aura, long history of migraine. Often they have a family history of this. The other aspect of hemiplegic aura where people get weak on one side associated with the migraine is that weakness can last a lot longer than a typical aura. A typical aura usually lasts up to 60 minutes. Hemiplegic aura can go on for days, and the weakness can go on for days. It is reversible, so people do completely recover, but it's very alarming, and it obviously requires treatment. And you can see here on the criteria that the International Classification puts in that there are two aspects to it. There's the fully reversible motor weakness on one side, and then the second one sounds like a typical aura, fully reversible visual, sensory, and or speech or language symptoms lasting the usual amount of time. This is much more rare, and we take this very seriously, and obviously people with hemiplegic aura need rather urgent treatment. There is also brainstem aura, and this has had a number of names over the years. It used to be called basilar migraine or basilar type migraine or Bickerstaff syndrome. And brainstem aura, again, the person has to have a history of typical aura. They cannot have weakness. And then they have some symptoms that seem to generate from the brainstem, such as slurred speech or vertigo or ringing in the ears. Sensitivity to noise, of course, can occur in everybody with migraine. Double vision, clumsiness with walking, a change in the level of consciousness or awareness. And again, brainstem aura is more rare. We take it very seriously. And again, people can have these symptoms and not have a history of migraine, not have typical aura, and then it's probably not migraine aura, migraine brainstem aura. So brainstem aura more rare and definitely requires very significant treatment to help people because it can be very disabling, but fortunately rare. Now, moving on, let's talk about the cause of aura. Aura is caused by nerves in the brain firing. And if the nerves fire in the visual part of the brain, then the person sees a visual aura. If the nerves fire in the part of the brain which receives sensation, they get a hemisensory aura. If the nerves fire in the motor part of the brain, they get weak on one side. And they can fire in a sequence, and they can move from one area of the brain to the next. And that's why people can have different kinds of aura in a row. but the aura itself is related to the nerves in that particular part of the brain firing. And we used to think that aura was caused by blood vessel changes. That's not true. It is really caused by the nerves firing. And the first man who actually mapped out his aura, and you on the left, was Lashley, and he figured out that an aura, that this had to move across the brain at a rate of about 2 to 3 millimeters per minute. And then in laboratory animals, it was found that you could cause the same kind of nerve firing. And this was called cortical spreading depression or cortical spreading depolarization, or CSD. And in animals, it seemed to move at the same rate as what Lashley had described in people. Now we know that's exactly true. That's exactly what happens. The nerves fire at a rate of 2 to 3 millimeters per minute in the important part of the brain that corresponds to what people see. And on the left, what you see is an area where the ribbon of red is increased blood flow that corresponds to the nerves firing. When the nerves fire, they have to get more blood flow. And then behind that in blue, the nerves have become quiet. The aura is related to that blood flow and that firing that has moved across the brain. After that, they are not firing. And so they originally, what people saw when they did the experiments was just the nerves not firing. That's how it was called spreading depression. But in fact, it's spreading activation. It's spreading depolarization. On the right, what you see is an actual person at Mass General in Boston who was in a functional MRI machine, and the oxygen consumption in the various parts of the brain was measured. And what happened was there was an increase in oxygen flow when the nerves in the visual part of the brain fired, and then the oxygen flow went down because the nerves were done firing. So the scientists could even see the firing of the nerves, the increased blood flow associated with the firing of the nerves, the increased oxygen consumption associated with firing of the nerves as this area of the brain fired and then moved on to the next area at a rate of 2 millimeters, 3 millimeters per minute. So that's the basis of the visual aura. You can see it firing across the visual part of the brain, the back of the brain there. And that really proved to everybody back in 2001 that we actually knew where and how. Here's another paper from even earlier, from 1994, of somebody who was in a PET scanner who said, oh, I'm getting a migraine. And she had a little bit of visual prodrome, but not a true aura. But it turned out she actually did have an aura, and it was occurring on both parts of the brain, and the PET scan picked it up. She was not in the PET scan for a migraine study. She was in for a different study, but fortunately, the doctors who were running the study kept the PET scan on so that you could actually see the cortical spreading depolarization, the cortical spreading depression, the CSD. That is the cause of the aura. That's the brain in the visual part there, firing slowly across time. So that explains what fires, where it fires, and now how does it fire? Well, it fires because generally a chemical called glutamate, which is a chemical neurotransmitter, docks with a particular glutamate docking station or receptor. This is called the NMDA glutamate receptor. And most aura is caused by the release of glutamate, and then glutamate binds to this docking station and turns on the aura in that particular part of the brain. This is not the same neurotransmitter that we have targeted in most of our migraine drugs, but it's quite specific for aura. But it is related to our old friend CGRP. And as we all know now, these new anti-CGRP drugs, the monoclonal antibodies, can be made against CGRP receptors or against circulating CGRP, which you see here in blue. Or in the United States, there are the medicines called Gepants, which are small molecules that can block the CGRP receptors. So we have multiple, in the United States, we have multiple kinds of medicines that target CGRP very specifically. We have 7 that have been approved since 2018. And it turns out that CGRP and glutamate are related, and that the CGRP can help the glutamate activate the NMDA receptor and turn on the aura. There's a relationship between the CGRP and the glutamate turning on the aura. And what you see in this picture is that when the red glutamate binds to the NMDA receptor, it's turning on the aura. You see the arrow going up into that part of the brain to turn on the aura. So there are ways of treating. One way that specifically target the NMDA receptor. One way is to take magnesium. And we usually do recommend that people with migraine aura take daily magnesium. And sometimes magnesium causes diarrhea so that people can't tolerate it. But for people that tolerate it, magnesium plugs the NMDA receptor so that the glutamate cannot get in there. And it can work preventively. It can work acutely in treating migraine and aura. And it's pretty well tolerated if you don't have a gastrointestinal problem with it. And it's safe and it's over the counter. So we use a lot of magnesium to treat migraine with aura. Memantine is also a drug that blocks the NMDA receptor. That's approved in the United States for the treatment of Alzheimer's. But it can also prevent migraine and aura because it works a little bit like magnesium. It blocks the NMDA receptor. Those are 2 medicines that are not approved by the United States FDA, Food and Drug Administration, but which we use pretty routinely in treating aura. We have other treatments that we do use for aura, and if it comes up in the Q&A, I can talk to you about it. But these are the simplest ones because they directly address the NMDA receptor. Now, some of the commonly used prescribed medicines do interfere with that spreading of the nerve discharge. Remember that spreading is called cortical spreading depolarization or cortical spreading depression or CSD, and topiramate and valproate, propranolol and amitriptyline, they all interfere with CSD. With valproate, propranolol, and amitriptyline, the effect on CSD, which would prevent aura, was observed only after chronic treatment and with higher doses. But with topiramate, it seemed to block the CSD and the aura even after an acute dose, 1 single dose. So our old-fashioned medicines that I don't particularly like, and most patients don't particularly like and are not specific, they do actually, to some extent, prevent aura and CSD. This single pulse transcranial magnetic stimulator is a device. It's called the STMS or Savvy or STMS Mini. It's a very simple device. It plugs in, you charge it, and then when you put it on the back of the head and press one of those 2 buttons on either side, it pulses a magnet, takes that long to pulse. And in the United States, it's cleared for the acute treatment of migraine. So at the beginning of a migraine or an aura, a person can pulse it 3 or 4 times, and that can terminate the aura, can terminate the migraine. And it's also approved in the cleared in the United States for preventing migraine, 4 pulses twice a day. And it can be used both ways, acutely and preventively. And I know of patients in Ireland who've been over to London to pick this device up and rent it. What's really interesting about this device is that it not only prevents migraine, but when a person pulses it, it stops the CSD, it stops the cortical spreading depression, it stops the aura. So it specifically stops aura, and it specifically can terminate a migraine with Aura, and then it also works on preventing migraine. That's a pretty interesting way to treat because it doesn't involve any drugs, and in the US, it's cleared for ages 12 and above. So this is actually one of the treatments that I bring up with patients. Unfortunately, it's quite expensive to rent in the United States. It costs $350 per month to rent. So that's a lot of euros, and really the patients have to be pretty well-to-do before they can afford it, which is really a shame because it's very, very useful in treating migraine with Aura. Now, again, talking about CGRP, there is all this interaction between CGRP and glutamate and the brain. Probably CGRP works mostly outside the brain, but in the meninges, but the effects of CGRP go into the brain. And CGRP, these monoclonal antibodies such as arenumab and galcanezumab and fremanezumab, those monoclonal antibodies do prevent migraine with Aura and migraine without Aura, just as they prevent both episodic migraine and chronic migraine. Probably the Aura part of it is that relationship that I showed you between the CGRP and the NMDA glutamate receptor. To summarize this, because it's a lot of information, the first point is from a diagnosis standpoint, to make the diagnosis of the Aura, the person has to have a reversible neurologic event, which lasts from 5 minutes to an hour. If it's just a few flashes of light before, that's not it. If it's occurring a day before and somebody gets nauseated and neck pain and food cravings, that's not Aura. Aura is a discrete event, 5 to 60 minutes in the typical form, visual, hemisensory, or speech or language. One can have all three and still be a typical Aura, but only about a quarter of those with migraine get Aura, and not necessarily with each migraine attack. The rare Auras involve weakness or other neurologic functions. They can last longer than 60 minutes, but remember, they're always associated with typical Aura. So if somebody's having those symptoms, but doesn't have any history of typical Aura or migraines, probably not migraine Aura, despite what somebody might suggest. But the cause of the Aura is the nerves firing in that particular part of the brain. And that is initiated by the activation of the NMDA glutamate receptor. And the nerves firing in that portion of the brain corresponds with the symptom. For example, a set of nerves firing in the visual brain cause the visual Aura. In the sensory part of the brain, the numbness and tingling. In the speech or language centers, speech or language dysfunction. In the motor part of the brain, weakness, and so on. And one way to treat that's simple is to try to block that NMDA glutamate receptor with magnesium. Sometimes memantine can be used, and these can be helpful in preventing or treating Aura. There are other treatments that are commonly used that are not officially FDA approved in the US, such as verapamil and anti-epilepsy drugs, and we'll try a lot of different aspects. The STMS device that I showed you can specifically treat Aura, and it can terminate migraine with Aura, terminate Aura, and prevent migraine with and without Aura. And the anti-CGRP drugs seem to prevent migraine with and without Aura, which is very good news for people with Aura. And we've really specifically looked at that. But remember, Aura is not the same as Prodrome. And then it's really important to make sure that what's going on is typical Aura and not something else.